The second part of the aged care training presentation will talk you through some of your daily duties on site, what you would be expected to do on a day to day basis, essentially your work description or your job description, and some of the common techniques and therapies that we administer to our residents. And it will also talk to you a little bit about our values as an organization. Massage and electrotherapy are not the only modalities we use on site to manage our residents. So, particularly at Portofino, which is quite a well equipped aged care facility with an on site gym as well as a pool, we do encourage a lot of exercise based therapy. Now, that exercise based therapy can actually be done either in room, one on one, or it can be done at the gym, or it can be part of a pool program that we develop, or it can be in terms of balance classes that we do weekly as well. So, all of these different modalities, which are pain management, exercise therapy, balance training, these are all part of your physiotherapy treatment. And the better you are at providing a combination of these treatments to residents, the better your clinical efficacy really will be. And you're likely to get better results from someone that you're actively managing pain for with massage and electrotherapy, but also taking for a walk, also encouraging them to go to gym with you twice a week, and also including them in a balance class once a week. That to me is more of a holistic way of managing residents than doing isolationary treatments like purely massage or purely exercise therapy. It's really that combination therapy that proves rather effective. Now, in terms of fall management and fall reviews, there is a bit of a protocol with that. And we do work very closely with the nursing team in order to manage falls, review falls, and then plan how to prevent falls. So, when a resident falls, or if a resident falls, a fall incident report is first completed by the on site registered nurse after the fall has been reported to her by whoever witnessed the fall. Sometimes falls are unwitnessed, but the person who first witnesses the fall or first witnesses the resident on the floor will then report that as an incident to the RN, who will then lodge an incident report. Once a fall has been reported, on site nursing staff have a responsibility to follow a protocol. And that protocol mandates that post fall reviews must be done by the doctor, by the nursing team, as well as by the allied health professional on site, which is generally a physio or an OT. So, your job as an allied health professional is to review a resident post fall. But a post fall review is a little bit different to just doing an assessment or a review on a resident. So, we're sort of thinking not along the lines of what is their strength rating like, what is their range of motion like. We're thinking more along the lines of what can I do to actively prevent this person from falling, and what are some of the factors, environmental, physical, cognitive, that could have led to this person falling. So I certainly want you to put your thinking cap on during these reviews from a fall management and a fall prevention perspective. And I want you to think about things like the lighting in the room, the clutter in the room, the furniture in the room and how it's been arranged. Does the resident try and get out of bed when the bed doesn't have brakes on? Is the resident using the walker when they're walking inside their bedrooms or when they're walking outside of their room? Is the resident not calling for the call bell? Or is the resident pressing the call bell but not waiting for assistance and getting impatient, trying to walk to the toilet by themselves and then having a fall? So these are some of the factors that can contribute to a resident's fall. Another very, very important factor that can contribute to a resident's fall are medications, particularly psychotropic medications. So if you find that a resident is sort of having idiopathic falls where there's no um, major contribution towards the fall from environmental factors like the lighting in the room, or clutter in the room, or slip hazards in the room. If the resident has good footwear, they are using their walker, they are pressing the bell, and they're still falling, then you might have to go along the roads of actually discussing with the RN whether it would be possible for the GP to review their medications. And you can check their medication charts on site as well to gauge and get a good idea about what sort of psychotropic medications, if any, they are on. So there's lots of things that go into fall management and fall prevention, and you probably won't learn everything in one go. But as you gain more and more experience in aged care, you will start thinking the way allied health professionals should think about falls. Um, Now, that is really how I want you to think about what contributes to a fall. So, the physical environment that the resident lives in, the lighting, the footwear they're wearing, how their furniture is placed, where the wheelie walker is placed if they need one, those sorts of things. But there are other factors or interventions that you have a responsibility to put in um, if a resident falls. Particularly if one resident is having multiple falls, or frequent falls, as we call them, frequent fallers, then we think about what sort of interventions we can put in place to prevent them from injuring themselves. So, for example, could we organize hip protectors? Could we organize head savers? Could we organize better footwear? Could we organize a bed sensor or a chair sensor or a room sensor that would set an alarm off, which would be heard by the nurses every time a resident tried to stand up or get up by themselves? So when you review a resident post fall, not only are you looking for signs of any injuries, have they had any fractures, have they got any bruises, have they got any skin tears, but you're also actively thinking about what could have contributed to this fall and what can I do to prevent this fall, what interventions can I put in place to prevent this kind of fall from happening again. Now, the other thing that we also do is obviously initial assessments and care plans. So when there is a new resident that enters the facility, we have to complete a comprehensive physiotherapy assessment and care plan, as well as a comprehensive mobility and transfer assessment and care plan. So each assessment that you complete has an adjoining care plan. Some of these care plans are automatically populated with information from the assessment, others you have to manually fill in. However, further training on how to complete a physio assessment and care plan and how to access them will be provided to you on site when, again, you're sitting across from the computer with the on-site software open for you to access. Manual handling is also a very, very important service that we provide to aged care facilities. When aged care facilities hire new nurses or office staff or laundry staff, they are constitutionally under legal obligation, as per aged care guidelines and aged care safety guidelines, to provide manual handling for all of their staff. Now, that manual handling on site is generally provided by the allied health professionals, which means that you will be in charge of. I just want to talk about some of our values and some of the values that I'd like to see reflected on site by you when you're representing RITCO. So we definitely like to say yes a lot, which means that we really want to work collaboratively with the nursing staff, and we want to try and go above and beyond the call of duty and provide to them as many services as we possibly can. For example, they might come to you one day and ask you to take a measurement for some hip protectors. We want to say yes to that. They might say, they need measurements done for a TED stocking. We want to say yes to that. So really, as much as possible, if we've got the time for it and we have the motivation for it, which you should do, we want to say yes a lot. Okay? So we motivate residents. And now I want you to be very aware of the fact that you will be working a lot with older adults as opposed to younger people in the community. A lot of the residents have chronic pain. They have many, many comorbidities, many, many conditions. sometimes multiple diseases. And it's very easy in that state of mind to not want to move or not want to be motivated to move. It's our job as therapists, as allied health professionals, to encourage them, to motivate them, to give them the positive energy that they need to feel positively about movement and exercise and pain management. And that is a huge part of your job, will be to motivate those residents to take pride in aging and age well. We work together with staff, and that links up very much to our first value of we say yes a lot. Okay, we have a very good working relationship with on-site staff. We certainly want to help them as much as we can, and we certainly want them to help us when we need help as well. So it really is a very, very dual relationship that we have with on-site staff. And I certainly don't want any of you to go on site and have issues where there are arguments that are happening with on-site staff members. So your communication and how you communicate with staff members is an extremely important part of your work, just as important as how well you communicate with the residents. I haven't said this before in the video, but I would like to mention a very, very important point that I always want you to remember. As opposed to working in a physiotherapy clinic or in a setting which is purely medical, aged care is different. And it's different because when you enter a residential aged care facility, you are entering the resident's home. It's where they live, it's where they eat, it's where they shower, it's where they relax, it's where they are going to eventually pass away. It's important that you respect that space and you create a work environment around you with staff and other residents which is positive, which is happy, and which is an environment where people help each other. Now, the fourth point there is we take on board recommendations for review from nursing staff and managers. So often, nursing staff will come up to you and say, look, I know you assess this person as requiring assistance of 2 nurses, but over the last few weeks, we've noticed that this particular resident has really improved and they don't need the assistance of 2 staff anymore. Can you reassess them to see if they can perhaps get away with being 1 assist? Now, I want you to definitely be the sort of therapists who take that feedback on board, because the nurses spend a lot more time with the residents, dressing them, showering them, feeding them, than often we do. And often they have a very good understanding of these residents. So if they're requesting a review of a resident, it is your obligation to review that resident. Now, of course, the final decision on what the transfer and mobility status of a resident will be is the allied health professionals. But as much as possible, we don't want to be resistive to reviewing a resident because the on-site staff member is somehow seen to be perhaps lower down in stature in terms of the work hierarchy there. We certainly want to work equally with the managers, with the clinical managers, with the registered nurses, as well as the AINs or the assistants in nursing, who often provide very, very handy and comprehensive feedback about a resident status. So we do work as a team, and we are always friendly, down to earth, and approachable. That is very important. I certainly don't want complaints about therapists from on-site staff saying that they were condescending or they were rude. And I'm sure that you all already know this, so I'm not going to keep talking about this, but I do expect you to be friendly and approachable to everybody that you interact with on site. So we are patient and compassionate, and patience and compassionate are 2 qualities that go hand in hand with aged care.